and I'll present for you our preliminary results. In the first 4 months of project implementation, we were able to test about 1,300 patients. Majority of those patients were male patients, and we found a hepatitis C antibody prevalence of 7.7%. Now, the good thing about the rapid test is because we're able to get them tested, give them the results, and do follow-up HCV RNA testing on the same day, we're able to get that follow-up testing in majority of patients. So that amongst the males, only 1 patient did not get HCV tested. And when we look at the number of patients who have active, ongoing chronic hepatitis C infection, 5.4% amongst the males. If we switch to the females, we found an HCV antibody prevalence of 5.2%. 3 women did not get HCV RNA tested because they had a history of injection drug use and we just could not access their veins. But of the patients who we did get tested, we did find that 4.3% of our patients were actively infected with hepatitis C. So high prevalence rates. I'll tell you that our HIV prevalence rates in the clinics are about 2%. So our hepatitis C rates are higher. Looking at the results in a different way, in the general STD population, so in the 1,300 plus patients we tested, our overall antibody prevalence was 6.7%. And of those, 5% of the total tested patients had evidence of chronic or active infection with hepatitis C. Now, focusing on the risk groups, the numbers in N's in brackets are the number of patients in those groups. I'll tell you that the 70 there are the people who said, yes, doctor, I used injection drugs sometimes in the past. I will tell you that's a gross underestimation. But of the 70 who said, yes, I may have used injection drugs at some point or the other, 88.6% were antibody positive. Looking at patients who are HIV positive, because we have over 400 patients in continuity care for HIV, majority of our HIV infected patients had previously been tested for hepatitis C, and so were not retested through this project. But of the 34 new diagnoses of HIV we had in that time period, 8.8% were also hepatitis C co-infected. Amongst men who have sex with men, 4% were hepatitis C infected, and in the birth cohorts, of the 192 patients tested, 31%, so 1 in 3 individual in that birth cohort tested in our STD clinics was infected with hepatitis C. Astounding numbers. So screening is great, but to reap the full benefits of screening, these patients need to be linked to care, and they need to get treated for hepatitis C. We're very excited with what we've been able to do in the health department with testing and linkage to care. Because what we are able to provide in the health department, the counseling on alcohol use reduction, prevention of transmission, medical education, is the beginning of comprehensive care for hepatitis C. But if you look at our graph, the zeros stand out. Because so far, none of our patients have gotten treated for their hepatitis C infection, and so none of our patients are currently cured of their hepatitis C infection, and this is why. That pie chart shows you the insurance status of our patients. In red are patients who have limited Medicaid. Limited Medicaid in Maryland is a primary adult care program, which will cover primary care, mental health services, insurance programs. It will not cover specialty care, and so these patients do not have access to hepatitis C treatment because majority of hepatitis C treatment is done by specialists. For the 12% of patients who have Medicare or Medicaid and 9% of patients who have private insurance, I cannot tell you how difficult it has been trying to get patients to be seen by a specialist. Now, we are very fortunate that we have a very close relationship with Hopkins, and we have specialists that are willing to work with our patients. Unfortunately, the way hospitals work, some hospitals accept some insurance programs and some don't. And it just happens that majority of our patients are on insurance programs not accepted. In conclusion, I hope hope I have been able to piggyback on what Bryce has so eloquently presented to show that hepatitis C is a major public health problem. And I will say in communities such as ours in Baltimore, probably even more than in some other places, medically underserved communities have been identified as areas where there does need to be a lot of emphasis on screening and linkage to care for hepatitis C. There is an urgent need for provision of resources for comprehensive viral hepatitis services. We've had a lot of success with rapid testing because that has allowed us to be able to get results to patients there and then. And I think that's central to being able to link those patients to care. With regards to our next step, we are looking to expand rapid hepatitis C testing to other sites, and there are other projects that have taken a cue from what we've been able to accomplish and are actually implementing rapid hepatitis C testing at other places in Baltimore. We're looking to expand and improve linkage to care for treatment services. And with all the exciting work going on with drug development and the availability of all oral regimens for hepatitis C treatments with high rates of care in the next couple of months to years, we are looking at being able to actually see our patients, diagnose the infection, and treat them right there at the health department. But the rate limiting step is always resources. Resources, resources, resources. But we're working on that, hopefully with your help. So these are the wonderful people I work with in the health department. We all take care of our patients together. Thank you very much for this opportunity. Thank you for being interested in hepatitis C. Thank you.